gentlemen, we are continuing our meeting, and as you know, we changed our headquarters from the University of Pécs to the Semmelweis University, which is not only a distinguished university also in Hungary and in Central and Eastern Europe, but also a center of excellence for pancreatic diseases. There is a really long background of pancreatic patients care and science at Semmelweis University, as we discussed with Attila earlier, that it's over 100 years now when the whole issue started. And there were two reasons why we came to Budapest. One of them is, of course, the university, and the second one is the brilliant pancreatic team, especially in the surgical department, which putting together our efforts, I think all together we can be better and we can provide better health care for the patients. So I'm very happy to introduce my co-chair, Attila, who is the head of the Department of Surgery, Gastroenterology and Transplantation. I don't know whether the English name was said correctly. And we will chair the forthcoming sessions, which I'm also very much looking forward to, the multidisciplinary way how it will look like. So the first presenter will be Tamás Hussein, and who is also a member of the Division of Pancreatic Diseases at Semmelweis University. Tamás, the floor is yours.
Thank you, Peter, and thanks for the opportunity to being here. It's a big honor for me. In the first part of my speech, I would like to say some general words about the multidisciplinary team discussions, which is written in the literature. And the second part of my speech, I would like to say some words about the MDTs in our center. Okay. So first of all, here you can see the general definition about the multidisciplinary team meeting in the NHS. As it's written here, it's a group of health and care staff who are members of different organizations and professions, example GPs, social workers and nurses, that work together to make decisions regarding to treatment of individual patient and service users. MDTs are used in both health and care settings. So this is, we can say it's a general definition for this, but let's see, in the case of oncology, we can find it in this article, and it's written that the MDT is defined as the cooperation between different specialized professionals involved in cancer care with the overarching goal of improving treatment efficiency and patient care. But let's see a bit more deeper. In the case of the gastrointestinal malignancies, which is found in this article, was published in Surgical Oncology, it's written that GI malignancy, the MDT, are responsible for changes in diagnosis and management in a significant number of patients. And also is written that all patients with GI malignancy should be discussed by an MDT. And here you can see the last sentence, a short history overview that you can see the MDT approach to patients with cancer has been described in the literature since 1975, so we can say it's not a new thing in the medical care. Let's see the benefits and the barriers, which was written in the literature in this Swedish article. We can see that nurses and coordinators report being less active in the case discussions, and I can see it's the same case in our department, but later I will discuss it, the details. And the MDTMs are rarely used to screen patients for inclusion into clinical trials. The focus on patients-related perspectives and preferences is weak. Practical implementation health professionals report strong benefit from MDTM related to support for further patient management. But in the next slide, you can see the short conclusion of this article. And it's written that the predominant MDTM benefits were compliant clinical information and review, multidisciplinary evaluation, and adherence to clinical guidelines. And here you can see the barriers to the need for supplementary investigations and the insufficient pathology. So these are the things that we can shortly find in the literature. And let's turn to the multidisciplinary team discussion in our center, Division for Pancreatic Disorders. But first, before I go to the details in the MDT case, please let me say some words about the center, about the beginnings. So the patient care began in 4th of October 2021. The profile of the institute is internal medicine, gastroenterology, and oncology. We have outpatient care in the gastroenterological and oncological field, and also we performed endoscopic examinations. The first chemotherapy was given in 22nd of February, so in this week, and the first MDT discussion was on 11th of October 2021. Let's see the aims of this discussion, as we know it in a general way, to integrate the opinions of professionals from different disciplines for the best treatment for the patient, and also it can because to improve the patient care. And here is a very important point that I want to mention: the 4/7 treatment, which we want to integrate for the daily health care. But it's mean that all patients have histological confined diagnosis within 4 days, and the therapeutic treatment is started within 7 days. In the next slide, you can see why it's important. As you can hear the previous day from the great specialist, and we also know it, that more than 95% of the patients diagnosed with pancreatic cancer died within 1 to 2 years. The 5-year survival is less than 5%. And the only curative care for the pancreatic cancer is surgery. And also I want to mention there was written in the literature, there is a few borderline cases, and it can be important to find them in the earlier stage to increase the survival of the patient. And the MDT, we are hope, will help us to integrate this treatment. And let's go to the next slide. Here you can see the specialists of the meeting, and I'm very thankful that they are here and we can hear interesting literature from them. But let's see them one by one. The surgeon, Ákos Szűcs and Tamás Marjai from Department of Surgery, Transplantation and Gastroenterology, Semmelweis University. Here we can find László Zubek. He's the anesthesiology specialist of this meeting, Department of Anesthesiology and Intensive Care. Attila Doros, who is the radiologist of this meeting, Heart and Vascular Center, also Semmelweis University. Katalin Bolkas is helping us with the histology. She's the pathologist, and she's from the 2nd department of pathology. Ágota Petrányi, she is part of the MDT discussion, but she helps us also with the oncological case, and she performed the chemotherapy in our ward. She's from the 1st department of internal medicine and oncology. The interventional endoscopist, you can find Ákos Pap, Péter Sahin, and Balázs Lázár. They are from our department, Division for Pancreatic Disorders. And also Péter Hegyi and Bálint Erős, also from our department, the gastroenterologist. Here you can see the dietitians, Olga Zahariev, Bettina Budai, and Luca Havelda, and they are part of the MDTs, and also they work in the ward, in the daily practice. Physiologist Beatrix Fogarasi and Sára Bognár also, and they are involved in the patient care too. And last but not least, Kitty Berlovic and Dora Todt, also in our center. They are responsible for the physiotherapy in the ward and in the MDT discussions. Let me say some features about this discussion. We have it twice per week, Monday and Thursday in 1 p.m. in the center. It's possible to join it in person and via Zoom. Prior to the discussion, case description will be sent to the participants online. It's a secure document, and only the participant had the key for it. So, and because of this, the patient data are safe. The decisions are recorded into the patient documents, and the meeting is in English language. Of course, we want to do it in international. Let's see some numbers. Here you can see between this period from 11th to October to 22nd of February, there was 145 cases discussed. And here you can see there was 180 cases, the malignant cases, approximately 80%, and the benign cases, 27 cases, approximately 20% of the all cases was discussed. Let's see what was achieved. Meeting twice a week, it's very good and we are happy for it. Not just discussing oncology cases, and as you saw in the previous slide, so it's good also. Close and good working relationship with the professionals, and we are very thankful for this. Patients receive treatment according to their choice. Clear guideline for documentation, and also we have clear guideline for informing patients. Facilitates patient referral between clinics, and shortness time from diagnosis to treatment. And as I mentioned before, the 4/7 treatment. So we want to do it good. But let's see the things that we must develop. The patient should be presented by the referring physician, and I just want to say it always must be referring. Physiologists, dietitians, and physiotherapists should be given a greater role in these discussions, and nurse and social workers should also be involved. And as you remember in my first slide in the NHS definition that was written, nurse and social workers. So we are work on this. All disciplines should be represented at all discussions. Here you can see that technology should be well functioning, and I think this is the major problem in the daily work because of the software, and sometimes it's hard to see the CT images, and without the CT images, it can be very hard to make a good decision about the case. Patient preferences should always be commented on. Role of every participant in the MDT should be clear, and we are working on it. And last but not least, the doctor who will continue to care for the patient should be named at the time of the decision. And also it's important for caring the patient. So as you can see, we have work to do, but I think in a good team, there is nothing impossible. Thank you for your attention, and I will be happy to answer your questions.
Thank you very much. Any questions from the floor? Okay, so how can you find, what is the number in the end of the year, which could be a possible treated person in your ward?
Regarding to the MDT discussions, at the end of 2021 or not? That was the number that I mentioned before. That was 148, but from this that was 120. I mean the patient, because the sign is okay. I think that was 100.
Anyone else? It's of course, I think the most important slides what you have put on were the two one with the red ones, because I think this is the only way to go forward. If we look at our limitations, the difficulties, the problems, and how we can go forward. I think the team started, and if I look at what is the biggest benefit that we started, we try to make copying in those centers which are absolutely going in high profile, also in Europe and worldwide. If we ask where we are currently, we are in a very beginners, but the major issue is that we are happy to learn. So thank you.
Thank you.
So the